Good evening, everyone. Welcome to Virtual Shadowing Session 79. Tonight, we have a specialty spotlight in psychiatry. I want to thank all of you guys for continuing to show up and support our program each and every week. Tonight, we are joined by Dr. Adam Brenner, who will be sharing his insight on psychiatry and how his journey brought him to where he is today. Next slide, please. Here is our working group, which is composed of Taylor, Rohit, Kiana, Elena, Shayan, Ali, and myself, as well as our faculty directors, Dr. Fowler, Dr. Salazar, Dr. Morchetti, and Dr. Reno. Next slide, please. So for our upcoming sessions, we have one more for the month of November and 3 for December. We will be taking a break for Christmas and New Year's. So on the 30th next week, we'll have a specialty spotlight in family medicine, followed by an emergency medicine and administrative side of medicine session with Dr. Compton Broders. On the 14th, we'll have another PM&R talk. And on the 21st, we will have a specialty spotlight in cardiology. Next slide, please. As always, we'll have 2 Q&A segments within this session, one at the halfway point and one at the very end. Please feel free to enter your questions into chat throughout the session. We will have our working group members sort the questions from high to low yield, and those questions will be presented during our Q&A slides. Please be sure not to direct message any of us your questions because they may get overlooked. Next slide, please. Dr. Fowler, would you like to say a few words?
Yes, we want to welcome you all. We've got folks attending all the way from Canada to Australia to Thailand, and of course, all over the United States, including God's country, which is Texas. It's so good to have you all. It's wonderful to have you coming back week to week. We think that we've seen quite a bit of activity on virtual shadowing activities. Dr. Brenner joins me as a member of the admissions committee here at UT Southwestern. And we're seeing quite a number of candidates submitting virtual shadowing hours for their applications for medical schools. So we'd like to think that you can get an opportunity to be able to interface with clinicians from all walks of life, to be able to decide what your pathway is going to be as you enter the field of medicine and or nursing. So we want to thank you for coming. We keep telling you week after week, if you keep coming back, we're going to be here. The program has been phenomenally successful. We've had now almost 500,000 viewings of the programs that we placed online. So clearly we're meeting a niche of some degree that seems to help you with your plans for your future. Anyway, thank you for coming. And Aditya, would you please introduce our guest?
Yes, sir. Without further ado, it is my pleasure to introduce Dr. Adam Brenner, a psychiatrist at UT Southwestern in Dallas, Texas, or as Dr. Fowler likes to put it, the modern day Sigmund Freud. Dr. Brenner will be sharing his medical journey, what psychiatry really entails, and what a day in the life of a psychiatrist looks like. Dr. Brenner, please take it away.
Hi, thank you very much. Thanks, Aditya. Thank you for your help with the technical stuff. We're doing our virtual interviews for our residency currently, and I've taken to telling the applicants at the beginning of we're doing them over Zoom. I've taken to telling the applicants at the beginning of the day that they're all very anxious that something is going to glitch and that it's not going to work. And I remind them that we're not interviewing them to be IT consultants. And so I appreciate you handling me with the same grace, since I don't have very much IT capability. So what I'm going to talk with you all about is I'm going to try to give you some sense of what psychiatry means to me, why I find myself in this field, in essence, really what I would do if you all actually were spending a couple of hours shadowing me. As Dr. Fowler said, he and I have been on the admissions committee for a long time, actually, Dr. Fowler. And our admissions committee very highly values shadowing. We really want to make sure that people who are coming into medical school know what they're trying to do, what they're getting themselves in for. So, and I've been very impressed over the last couple of years of how much educationally we've been able to migrate from in person in our residency and with our medical students, how much we've been able to migrate into Zoom. And I think it's wonderful that shadowing is happening the same way. So let's see, where am I going to start? I'm going to start with defining psychiatry. In some ways, the first thing to do with defining psychiatry is often to explain how is it different from neurology, and why aren't these fields one field? We both treat the illnesses of the brain, right? The distinction is that psychiatry treats the illnesses of the brain that present as subjective experiences or present as behaviors. That's basically it, right? So we and our neurology colleagues are close siblings in medicine. We're treating the same target organ, the brain. But we're treating things that present as subjective experience, which means the mind, and things that present as maladaptive or troubling behaviors. And if we're talking about behavior and how people act and what makes a behavior considered acceptable or not, then we're talking about culture. So one of the things that draws many of us to psychiatry, and certainly one of the things that drew me to psychiatry and keeps me completely in love with this field to this day, is that we operate at the intersection of mind, brain, and culture. And we can't really take care of our patients without thinking in all of three of these modes. Now, it's hard to do anything in psychiatry and to get any kind of experience about seeing patients without knowing something about the DSM, the Diagnostic and Statistical Manual. This is how we diagnose things in psychiatry. We have a book. This means that when I say that we have this book because of what we don't yet have. But what we don't yet have are blood tests or spinal fluid tests or imaging studies that can make a diagnosis of a mental illness. I'm going to say more about all of those things because that's all coming, but we're not there and we've never been there. And so what we have is we have to make diagnoses based on people's what people report and what we observe. One of the things that that draws many people into medicine as a whole is that people like coming into a field where they will be listening to people and making diagnoses based on spending time exploring people's history and their symptoms. We often find that there are people who come into medical school and have never thought about psychiatry before, but wind up coming into the specialty because they experience us as one of the places where that is still a great priority, because it's still really the primary tool that we have. So how do we diagnose something in the DSM? Based on observable or reportable experiences or behaviors, which basically means checklists of signs and symptoms. And the symptoms have to be associated with distress, disability, or danger. In other words, in order for us to make a diagnosis of a mental illness, we've got to have symptoms, but we've also got to have symptoms that are troubling somebody, that are causing difficulty functioning, or that are causing some real threat to safety. We also have to specify what it's not. So if those symptoms, even if distressing, are culturally explainable or expectable in the course of life, in the way, for example, that someone who's grieving may hallucinate the presence or the voice of the person that they've lost, and that can be disturbing and cause pain. But in many cultures, that's a very common expression of grief. That means that it's not a mental illness. So that's a vague general way of saying how we go about making diagnoses. Now, this is what it looks like in the details. This is literally the text of a diagnosis from the DSM. So I decided to take the example of schizophrenia for today, partly because schizophrenia was one of the first experiences that I had of a patient in medical school. I think early in our second year in medical school, we began having experiences meeting psychiatric patients, and our small group met a patient with schizophrenia. And I vividly remember that experience because I remember how it felt. I remember that it was intellectually very, very interesting. It was very poignant because the person was in great distress. And it was also scary to me because it also was one of those experiences of seeing an illness and meeting a patient that left me with the feeling of, what if that happened to me? So I remember being frightened by it. And so I wanted to learn about it. And so the first thing that we do in learning something in psychiatry is we open up the DSM and we see, how do you diagnose this? So here it is. You have to have 2 or more of these symptoms for a significant period of time during a 1-month period: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and then negative symptoms. Negative symptoms are in some ways the hardest thing. A delusion means a false belief that you can't convince somebody out of. A hallucination is a perception of something that's not there. Voices, visions. Disorganized speech is what it sounds like. It's when people are talking in a way that doesn't make sense or doesn't seem logically coherent. Disorganized behavior also is kind of as it sounds. The negative symptoms take some of the greatest toll to people living with schizophrenia. And that means, and what those things are that people get sort of emotionally less responsive. They lose some of their motivation. They lose some of their capacity to just engage with life. So those are the core symptoms.
Adam, let me ask you about the hallucinations. I know in the ER that we generally think that schizophrenia is auditory and visual hallucinations is more delirium, like methamphetamine associated, PCP associated. Is that true, or am I mistaken?
It's true in the sense that it's more often, right? But there are very few things in psychiatry and in all of medicine where the boundaries are very clear cut. So by far the most common hallucination in schizophrenia is auditory, is hearing voices. But a significant minority of people will also have visual hallucinations too. But that's a significant minority, as opposed to if people are delirious, meaning that they've got something currently medically going on that's really just causing a toxic experience for their brain, then the most common hallucination is visual. So this is what it looks like from the psychiatrist's perspective, and this is what we're trying to do. We're trying to look at these psychotic symptoms, delusions, hallucinations, thought disorder, these negative symptoms, And then we're wanting to make sure that it really causes difficulty in functioning. That's what Part B is about. And then that this needs to last for at least 6 months. So basically what we're saying is that this is a very serious illness. This is an illness that's going on for months, has symptoms that are disturbing and probably frightening to the patient and to people around them, and is causing real difficulties functioning. That's what it looks like from the psychiatrist's perspective.
Does
Now,
age of onset factor into this? Because I know we think a lot about teenagers when they have their first episode, but yet if it happens much later in life, it could be something else, a stroke or dementia or something.
yes, the most common, most of the time, the age of onset for schizophrenia is in young adulthood. So late adolescence or early adulthood. But there are people who develop what looks like schizophrenia late in life as well. Now, this anticipates one of the things that I'll say in a slide in a little while, which is one of the things that probably means is that I'm describing here a syndrome. And one of the things that you're going to see again and again in medicine is that syndromes, meaning a way that a way of an illness presenting a set of symptoms and signs, can be from different causes and can ultimately be several different diseases. Most of us in psychiatry think that when we talk about schizophrenia, we're probably talking about several things. So this is schizophrenia from the psychiatrist's perspective. I thought that though Dr. Fowler, I think you're muted.
Oh, so sorry. Adam, we just got a great question. How do you treat people who don't recognize that something is abnormal about their mental state?
Oh, my goodness. That's one of the things that's most challenging in psychiatry. And that's a beautiful question, because the fact is that learning those symptoms, learning that checklist, that's not very hard. It's not very hard to learn that checklist. It's a little bit harder to learn to interview somebody, to ask them to tell you in ways that, are really both sensitive and precise, to tell you about the symptoms. But that also, most medical students can do a really good job at that within, a few months of practice. What's much, much harder is forming an alliance with somebody who may not feel that they're ill. And this is one of the things that's very, very challenging in psychiatry, is that most of the time, people in other fields in medicine, most of the time, when people are very sick with a serious or chronic disease, they come to the doctor and they say, I'm very sick and I want your help. That often happens in psychiatry, but it's also often the case that it doesn't. And so then what do? You try very hard to help the patient develop some insight into the illness. You try hard, if you can't help them develop insight into the illness, to at least feel that you're somebody trustworthy who's trying to help them and whose advice they may still want to follow, even if they don't quite see things eye to eye with you. And then finally, sometimes you don't succeed. And sometimes it takes many invitations to someone over numerous times. Sometimes that's numerous trips through the emergency room. Sometimes that's numerous times starting and stopping an outpatient treatment. I have a patient with a bipolar disorder who's started treatment with me again about 6 months ago and is now taking medications. This is the 4th time that he's started treatment with me, or that he's come to try to start treatment with me. First time was 10 years ago. So it's taken a number of false starts before he could get to a point where he can see that there really is something, and that I might have something to offer. And I feel that our work has been very successful simply because I left him with enough of a feeling of trust in me that even though he disagreed with me and would drop out of treatment after a couple of months, a couple of years later, when things got bad for him, he'd keep coming back. So, and then finally, there are some times where psychiatrists force people into treatment through the courts. And that is a very serious and difficult thing to do. And we do it only when people are both very, very ill and in grave acute danger.
You know, we got a good question from AJ. He said he works clinically, and he says he's seen bipolar manic episodes. Mania resembles schizophrenia. Just for jollies, could you comment on that?
Oh, I had a whole slide about this that I took out because I thought it might be getting too much into the weeds. But this is a major area of interest at UT Southwestern in our Department of Psychiatry, because patients can become psychotic, meaning hallucinating or having disordered thoughts, out of touch with reality, as an end result of several kinds of illnesses. So that can happen in schizophrenia, but it can also happen in bipolar disorder. And it's not easy when people are very psychotic to tell the difference. Sometimes you can, because sometimes if it's a person with schizophrenia who's got a lot of negative symptoms, then they're not likely to look manic. Mania is a state of high energy and intensity along with the psychosis. And so sometimes you can tell the difference, but often when we meet a person in the emergency room who's very psychotic, we're not at all sure. We're not at all sure. Now, over time, if you follow the patient, the course of these illnesses are quite different. And this has been known for 150 years. Some of the earliest great diagnosticians in psychiatry, the people who really invented the category of bipolar disorder, manic depressive illness, and schizophrenia, the first great observation that they made, a man named Emil Kraepelin, great diagnostician in Germany, his great observation was that these people were both very sick, but some people had a remitting and relapsing illness that came in cycles. And in between, they got quite well again. And he called that manic depressive illness. And some people seemed to stay sick and get progressively kind of worse over time and never quite come back to their full healthy selves. And he called that schizophrenia. And the courses of these illnesses do look different. Now, the reason that I say that this is a great interest to us in our department at UT Southwestern is that our chair, Carol Tamiga, is an expert in the neurobiology of psychosis. And she's been searching for years to try to define what are what we call the biomarkers of this illness. You know, I said before that we don't have imaging tests and blood tests and EEGs and things that can tell us, is this bipolar disorder or is this schizophrenia? So her research group, along with a consortium of research groups from around the world, have been doing this project over the last 10 years to see if they could do every kind of brain assessment possible on people with bipolar disorder and schizophrenia and come up with what are the underlying biomarkers so that we could do what's being asked about. When somebody shows up in the emergency room and gets admitted to the hospital and they're acutely psychotic, so that we would know. And the short answer is they looked at every possible way that we have of measuring some kind of activity in the brain, and none of it sorted out to bipolar disorder or schizophrenia. None of it. What was fascinating, though, was that when they took a step back and looked at all of the data again, they did find that it wasn't random. What they found was that there were biotypes. In other words, some of these different kinds of studies tended to group together. so that there was a group of people who had various kinds of studies like EEGs and other things that showed kind of a lot of brain activation in different ways. Another group of people that showed a lot of slowing in all kinds of cognitive functions. And they called these biotypes. And the biotypes actually seemed to correlate with the same tests in people's relatives. So there did seem to be something to this, but they didn't sort out according to the diagnoses. They didn't sort out to bipolar disorder or schizophrenia. So we are still at the beginning of understanding what to make of that. If I have left you confused by that explanation, then you are doing well. You are understanding perfectly.
Adam, you used a word a moment ago I'd like to return to. You, I remember many years ago, I think it was at Parkland, I admitted a guy who was psychotic. I don't recall if it was schizophrenic specifically, but he was psychotic and he was admitted to the psych unit. And I recall following up on him, and the psychiatrist used this phrase, or I'm paraphrasing, it said, after a few days, this is on the discharge summary, after a few days, the patient became more organized or became reorganized and was a candidate for discharge. And I thought that was very interesting. That was the first time I'd heard that, but it makes great sense from the way you're talking about lack of organization versus organization.
Yes. So what do we mean by that? Generally, one of the things that's interesting about learning psychiatry is that you come to learn how much you take for granted. One of the things that we take for granted is that in talking to each other, we can follow what people are getting at. You may not understand every concept or every term, but you generally have a sense that I am trying to make a point. You know what point I'm trying to make, and you can follow along how I'm trying to get there. You may agree or disagree with things that I'm saying, right? But you can follow along and it makes sense where I'm going and why I'm going there. The capacity to do that, to stay on task like that, to have thoughts move in progression like that in a way that makes sense, that gets lost when people are psychotic.
Adam, God, that was great. This is so good. I read last year Nick Chater's wonderful book, The Mind is Flat, and I've actually put it on the website as a suggested reading. And he talks a great deal about the way that Freud said that, 99% of our mind is the unconscious, and this tiny sliver is the conscious. And the only way the conscious relates to the unconscious is through dreams, hence Freud's on the interpretation of dreams. Otherwise, they don't intercommunicate. Chater, who's an English psychologist, and he actually reads the book on the audiobook, he said that's nonsense. He said what our minds actually are made of are our memories. Those memories can be quite complex. What were we wearing? What was our emotional state at the time? And so on. But it really, as if it was like a stack of stacked cheese, that really what our mind is our memories through our experiences. Is Chater full of crap, or what's your view on that?
Chater is, in my view, is getting part of the picture. So the mind is, memories are core ingredients of constructing the mind. But we do things with those memories, with both narrative memory of experiences, and memory of things we've learned, ideas, and we combine them together in all kinds of new ways all the time, right? So the stacking of memories doesn't get at the creative and functioning and working aspect of the mind. In other words, our minds are constantly putting things together and trying to make sense of them. And so this Freud talked about, and this is quite true, that the mind is organized dissociatively. we don't have things organized in the mind like a file folder in a computer where each thing is just in its place and you have to go and find the exact place. Instead, imagine, and I imagine there are computers that can do this now, but if all of the files can be connected to all of the other files, and what's going on and what matters is the way in which things are at any point, the patterns of connection. So I don't know Shader's book, but I'll tell you, Dr. Fowler, you probably would enjoy this other book that I'm just finishing called Oracle of the Night, which is a recent book by a neurobiologist about dreaming. And he does a very nice job of describing that the connection between dreams, as far as we haven't figured out everything about the function of dreams and sleep, but one thing that is pretty clear at this point is that sleep and REM sleep, where dreaming occurs, is essential for learning and the consolidation of memory. And one of the things that's fascinating, though, is that it's also a place where people experience themselves often at their most creative, and also then at the place where they get in contact with things that are most disturbing. So the part that's certainly true is that what we're aware of consciously, what we can present to our own selves as what I'm thinking about right now, is a tiny fraction of the amount of work that's going on associatively in our minds at any point. It's truly just the tip. What we're aware of consciously is the tip of the iceberg. And that, it's an interesting thing, because when I was a resident 25 years, 30 years ago, Freud had fallen out of fashion. And there were many people in psychiatry who would have disagreed with what I just said, that a vast amount of mental function is unconscious. That's indisputable now. And it's indisputable not because of psychoanalytic research. It's indisputable because of cognitive psychology and social psychology research. There's an enormous and wonderful literature that demonstrates unconscious mental functioning. Now, Freud thought that some of what goes on in the unconscious is unconscious because it's too disturbing for us to experience consciously. That part's still debatable, but I'll tell you, as a clinician, I don't have any doubt about it.
Just to let you know, I just bought the book while you were talking. That's great. That's marvelous. One last thing, Adam, if I may. I'm very interested in the mind. I realize I know so little neuroanatomy. We just had this morning the pediatric emergency medicine conference together with the pediatric radiology. And I'm astounded that the pediatric radiologists know every micron of the cross-section of the brain in all areas and the Latin names for them. And I'm humbled by what I don't know. But I will say that from the time of the appearance of computers, which really is only the 1970s, the thinking was that the brain was really kind of a digital binary organ. But current evidence seems to suggest that is not at all the case, that the brain is not some digital binary computer. And could you make some little comment about that? And then we'll move on with what is your presentation?
Oh, boy. This is stuff that is fascinating and beyond my scope. I'll say that because what it gets at is the issue of this is about information and information theory and how information is processed. I mean, it is the brain. The binary aspect of it is the fact that a neuron either fires or doesn't fire, but what's not binary at all is that every neuron has thousands and thousands of inputs coming into it from other neurons, and how complicated it is, all of those inputs, and how things get balanced out and calculated about whether then that neuron will now fire and be a link in an ongoing chain of associations. But this is above my pay grade.
Mine also.
Now, if you ask Dr. Taminga to do this, you're going to get a much better answer. Now, so moving on to
absolutely.
This is really the main thing that I think I wanted to have you all do is I'm going to have you all watch a TED Talk by Ellen Sachs. Ellen Sachs, this is her book. It's my favorite book to recommend to people who are interested in psychiatry. Professor Sachs is a professor of law at University of Southern California. She won a MacArthur Genius Award some years back and used the money to form to start an Institute of Mental Health Law. That's one of her areas of expertise. And she has been living with schizophrenia for her whole adult life. And so she has a wonderful TED Talk, and I met Professor Sachs at a conference where she spoke. I think there's a wonderful chance to get to hear from someone with schizophrenia really what the experience has been like. This is 15 minutes. I think, Dr. Fowler, we'll let it run for 5 or 8 minutes. We'll see. At a certain point, I may think that you've gotten enough of a sense of it, and we'll stop and we'll let people finish it up on their own.
Sounds great, Adam. Let's roll.
Okay. So now let's see. Now I've got to unshare this and find my
So I've got my essay written, and I've been working on it for about a week.
Oh, let's see. Maybe I pulled up I thought I had it all queued up.
We don't mind a quick commercial.
And now it's promising me I can skip the ads.
Skip it. There you are.
Yeah.
So I'm a woman with chronic schizophrenia. I've spent hundreds of days in psychiatric hospitals. I might have ended up spending most of my life on the back ward of a hospital, but that isn't how my life turned out. In fact, I've managed to stay clear of hospitals for almost 3 decades, perhaps my proudest accomplishment. That's not to say that I've remained clear of all psychiatric struggles. After I graduated from the Yale Law School and got my first law job, my New Haven analyst, Dr. White, announced to me that he was going to close his practice in 3 months, several years before I had planned to leave New Haven. White had been enormously helpful to me, and the thought of his leaving shattered me. My best friend, Steve, sensing that something was terribly wrong, flew out to New Haven to be with me. Now I'm going to quote from some of my writings. I opened the door to my studio apartment. Steve would later tell me that for all the times he had seen me psychotic, nothing could have prepared him for what he saw that day. For a week or more, I had barely eaten. I was gaunt. I walked as though my legs were wooden. My face looked and felt like a mask. I had closed all the curtains in the apartment, so in the middle of the day, the apartment was in near total darkness. The air was fetid, the room a shambles. Steve, both a lawyer and a psychologist, has treated many patients with severe mental illness, and to this day, he'll say I was as bad as any he had ever seen. "Hi," I said, and then I returned to the couch where I sat in silence for several moments. "Thank you for coming, Steve." Crumbling world, word, voice, tell the clocks to stop. Time has come. "White is leaving," Steve said somberly. "I'm being pushed into a grave. The situation is grave," I moaned. "Gravity is pulling me down. I'm scared. Tell them to get away." As a young woman, I was in a psychiatric hospital on 3 different occasions for lengthy periods. My doctors diagnosed me with chronic schizophrenia and gave me a prognosis of, quote, grave. That is, at best, I was expected to live in abortant care and work at menial jobs. Fortunately, I did not actually enact that grave prognosis. Instead, I'm a chaired professor of law, psychology, and psychiatry at the USC Gould School of Law. I have many close friends, and I have a beloved husband, Will, who's here with us today. Thank you. He's definitely the star of my show. I'd like to share with you how that happened and also describe my experience of being psychotic. I hasten to add that it's my experience because everyone becomes psychotic in his or her own way. Let's start with the definition of schizophrenia. Schizophrenia is a brain disease. Its defining feature is psychosis, or being out of touch with reality. Delusions and hallucinations are hallmarks of the illness. Delusions are fixed and false beliefs that aren't responsive to evidence, and hallucinations are false sensory experiences. For example, when I'm a psychotic, I often have the delusion that I've killed hundreds of thousands of people with my thoughts. I sometimes have the idea that nuclear explosions are about to be set off in my brain. Occasionally, I have hallucinations, like one time I turned around and saw a man with a raised knife. Imagine having a nightmare while you're awake. Often, speech and thinking become disorganized to the point of incoherence. Loose associations involves putting together words that may sound a lot alike but don't make sense. And if the words get jumbled up enough, it's called word salad. Contrary to what many people think, schizophrenia is not the same as multiple personality disorder or split personality. The schizophrenic mind is not split, but shattered. Everyone has seen a street person, unkempt, probably ill-fed, standing outside of an office building, muttering to himself or shouting. This person is likely to have some form of schizophrenia. But schizophrenia presents itself across a wide array of socioeconomic status, and there are people with the illness who are full-time professionals with major responsibilities. Several years ago, I decided to write down my experiences and my personal journey, and I want to share some more of that story with you today to convey the inside view. So the following episode happened the 7th week of my first semester of my first year at Yale Law School, quoting from my writings. My 2 classmates, Rebel and Val, and I had made the date to meet in the law school library on Friday night to work on our memo assignment together, but we didn't get far before I was talking in ways that made no sense. Memos are visitations, I informed them. They make certain points. The point is on your head. Pat used to say that. Have you killed anyone? Rebel and Val looked at me as if they or I had been splashed in the face with cold water. What are you talking about, Ellen? Oh, you know, the usual, who's what, what's who, heaven and hell. Let's go out on the roof. It's a flat surface, it's safe. Rebel and Val followed, and they asked what had gotten into me. This is the real me, I announced, waving my arms above my head. And then, late on a Friday night, on the roof of the Yale Law School, I began to sing, and not quietly either. Come to the Florida sunshine bush. Do you want to dance? Are you on drugs, one asked. Are you high? Hi, me? No way, no drugs. Come to the Florida sunshine bush, where there are lemons, where they make demons. You're frightening me, one of them said, and Rebel and Val headed back into the library. I shrugged and followed them. Back inside, I asked my classmates if they were having the same experience of words jumping around our cases as I was. I think someone's infiltrated my copies of the cases, I've said. We've got a case to joint. I don't believe in joints, but they do hold your body together. It's an example of loose associations. Eventually, I made my way back to my dorm room, and once there, I couldn't settle down. My head was too full of noise, too full of orange trees and law memos I could not write and mass murders I knew I would be responsible for. Sitting on my bed, I rocked back and forth, moaning in fear and isolation. This episode led to my first hospitalization in America. I had 2 earlier in England. Continuing with the writings. The next morning, I went to my professor's office to ask for an extension on the memo assignment, and I began gibbering unintelligibly as I had the night before, and he eventually brought me to the emergency room. Once there, someone I'll just call the doctor and his whole team of goons swooped down, lifted me high into the air, and slammed me down on a metal bed with such force that I saw stars. Then they strapped my legs and arms to the metal bed with thick leather straps. A sound came out of my mouth that I'd never heard before. Half groan, half scream, barely human, and pure terror. Then the sound came again, forced from somewhere deep inside my belly and scraping my throat raw. This incident resulted in my involuntary hospitalization. One of the reasons the doctors gave for hospitalizing me against my will was that I was, quote, gravely disabled. To support this view, they wrote in my chart that I was unable to do my Yale Law School homework. I wondered what that meant about much of the rest of New Haven. During the next year, I would spend 5 months in a psychiatric hospital. At times, I spent up to 20 hours in mechanical restraints. Arms and legs tied down, arms and legs tied down with a net tied tightly across my chest. I never struck anyone, I never harmed anyone, I never made any direct threats. If you've never been restrained yourself, you may have a benign image of the experience. There's nothing benign about it. Every week in the United States, it's been estimated that 1 to 3 people die in restraints. They strangle, they aspirate their vomit, they suffocate, they have a heart attack. It's unclear whether using mechanical restraints is actually saving lives or costing lives. While I was preparing to write my student note for the Yale Law Journal on mechanical restraints, I consulted an eminent law professor who was also a psychiatrist, and said surely he would agree that restraints must be degrading, painful, and frightening. He looked at me in a knowing way and said, "Ellen, you don't really understand. These people are psychotic. They're different from me and you. They wouldn't experience restraints as we would." I didn't have the courage to tell him in that moment that no, we're not that different from him. We don't like to be strapped down to a bed and left to suffer for hours any more than he would. In fact, until very recently, and I'm sure some people still hold it, is the view that restraints help psychiatric patients feel safe. I've never met a psychiatric patient who agreed with that view. Today, I like to say I'm very pro-psychiatry, but very anti-force. I don't think force is effective as treatment, and I think using force is a terrible thing to do to another person with a terrible illness. Eventually, I came to Los Angeles to teach at the University of Southern California Law School. For years, I had resisted medication, making many, many efforts to get off. I felt that if I could manage without medication, I could prove that, after all, I wasn't really mentally ill. It was some terrible mistake. My motto was the less medicine, the less effective. My LA analyst, Dr. Kaplan, was urging me just to stay on medication and get on with my life, but I decided I wanted to make one last college try to get off, quoting from the text. I started the reduction of my meds, and within a short time, I began feeling the effects. After returning from a trip to Oxford, I marched into Kaplan's office, headed straight for the corner, crouched down, covered my face, and began shaking. All around me, I sensed evil beings poised with daggers. They'd slice me up in thin slices or make me swallow hot coals. Kaplan would later describe me as, quote, writhing in agony. Even in this state, what he accurately described as acutely and floridly psychotic, I refused to take more medication. The mission is not yet.
I'm going to stop there.
Dr. Brenner, whenever you reshare your screen, if you could unclick those 2 boxes in the bottom left about the video share, I think we see some blue boxes over your screen share, so it should get rid of that.
Okay, let's see.
Adam, while you're doing that, we had a good question that came up. Is the United States going to be building more or less state-type mental facilities? And I mentioned that UT Southwestern will be building a inpatient mental facility on our campus here over the next few years. And then Brandon said, do we think that having a mental hospital on the UT campus will reduce the number of psych patients in Parkland ER? I said, no, it's going to increase them because now we'll have a place to put them. You remember we had the state hospital down halfway to Austin, Adam. We had 200 beds there. There are more or less. And then when we lost that hospital, when they closed it, we lost 200 inpatient beds. Anyway, fascinating talk from an obvious genius who clearly has struggled with, she says, brain disorder. Could you elaborate a little bit more? Is there not a biopsy you can take on the brain and said, oh, this is a schizophrenic brain?
Oops, here we go. Well, so this slide gets right to what we're wondering about. The answer is no. There are, if you look at a large population of people with schizophrenia, you can find trends of things that'll show up on functional imaging, or that would show up in an autopsy. You can see parts of the brain that haven't developed as well. The hippocampus is one. Sometimes there's areas of the brain that are generally word I'm looking for. Well, that seem to show some atrophy, but it's not true in by any means with every patient. It's nothing that we can use to make a diagnosis. And part of the problem is that we are probably still dealing with multiple different illnesses that we call schizophrenia. So, as we learn more about specific causes of psychosis, things that have been bundled into the illness get pulled out. One of the first was the appreciation that some people with psychosis 100 years ago realized that this was actually from syphilis, and we had an actual cause. The most recent, it probably would be autoimmune encephalitis. If you want to read a wonderful memoir about that, Brain on Fire is a terrific memoir of a young woman, Susan Cahalan, a terrific writer who presented and was thought to just have a psychotic illness and probably going to turn out to be diagnosed ultimately with schizophrenia, but she had an autoimmune encephalitis. There may be multiple things that present in what we currently call schizophrenia. And so part of the problem is that when we look at what you're asking about, Dr. Fowler, well, are there some specific neuropsychiatric abnormalities that we could see if we did a biopsy or if we did imaging? There may be for some kinds of subgroups within that large group of psychotic patients, but we don't know how to sort that out. So we are at a stage in the appreciation of psychiatry that's in some ways decades behind where we are in internal medicine. Imagine when congestive heart failure was just understood to be about patients who had too much fluid building up in the lungs because of something going wrong with the heart, right? And that was all that one knew. Now, if I tell you that somebody had congestive heart failure, you would immediately have a sense, well, that's a very broad category, and there are a whole bunch of very specific illnesses that cause congestive heart failure and that you're going to treat in very, very different ways, depending on what's actually at the bottom of that congestive heart failure.
Is it ischemic due to clogged up arteries? Is it immune, attacking the heart muscle, and the list goes on?
Right. So we are at the beginning of being able to sort out that kind of thinking in psychiatry. And it's not because psychiatrists and neurobiologists haven't been trying. It's because, frankly, the brain is simply that much more complicated than every other organ. It's an staggeringly complicated. organ. So what do we know? We can say some things, though. Okay, we can say some things about what is causing schizophrenia, and here's what we can say: it's complicated. It's not turning out to be simple, right? So we know that schizophrenia sometimes runs in families. So we know that there are genetic things involved, but the genetics don't turn out to be simple. It's not certainly an illness like Huntington's disease, where there's a single gene that causes the brain to have a disease. People with Huntington's disease also can become psychotic and then demented, and there's a single gene that's at work. There are hundreds of genes that have been shown to increase the risk for schizophrenia. And to make things even more complicated, most of those genes also increase the risk of other serious mental illnesses. Now, to make things even more complicated, the epigenetics probably is just as important with schizophrenia as the genetics. And by epigenetics, we mean the things that turn a gene on or off, right? Because most of the genes in any given cell are not being used to currently code and produce protein, right? So what matters is what turns something on or off. The other thing that we know is that unlike, I said that, you can see some things in imaging with some patients where there are atrophies in some parts of the brain, but that's not true with the vast bulk of patients. If we did images of their brains, these young people with schizophrenia, we took them in the ER and put them in the MRI, you wouldn't see anything. But it's not that their brain doesn't have a disease. It's that their brain probably has a disease that has more to do with circuit function, with how different parts of the brain communicate and collaborate together. That's much more complicated. Now, over time, brain circuit malfunction can and does lead to specific areas being having problems of structure, but we're talking much more about problems of function and problems of circuits. Now, I said that we know that the epigenetics is important in terms of, and things turn genes on or off. The main thing that psychiatry has learned since I was a resident 25, 30 years ago is that it's social experiences that turn out to be probably the most important kinds of things, what we call the social determinants of health or the social determinants of mental health. I told you before about our chair, Dr. Taminga, who does all of this wonderful work looking at the underlying biomarkers of psychosis. I asked her recently if she thought we were at a point where, even though we don't understand all of the neurobiology, are we at a point yet where we could actually do anything to prevent psychosis? And she, without missing a beat, she said, absolutely. Absolutely. Reduce childhood trauma and reduce poverty. Oh, and she added, marijuana use.
No question, Adam. And I was going to get into that with you about, can someone be rocking along with sort of a subclinical schizophrenia, but getting along okay, holding a job, having a family, but then get on to substances, whether it's booze or meth or pot, and actually bring out the schizophrenia, unroof it, or whatever the clinical word would be?
Sure, because a brain that's at risk for developing schizophrenia has some vulnerability and fragility, and anything that's bad for the function is going to increase the risk of that person's trajectory taking a bad turn. I said marijuana because it turns out that one of the strongest recurring findings is that we've all come to appreciate over recent decades that when I was a kid, marijuana was completely demonized, and it's taken decades for us as a society to get to a point where we are more sane about marijuana, but we've swung to a point where now many people think that it's got no real risk at all. And what we find in psychiatry is that it's got much, much, much less risk for people my and Dr. Fowler's age than for people for young adults and late adolescents. That is the age, late adolescence, where marijuana use really does increase the later risk of developing schizophrenia. But a trauma and childhood adversity are very powerful causes of later psychosis. And all of these things have been shown to increase the risk in populations of developing psychosis. Childhood trauma and abuse, poverty, racial discrimination, migration, all of these kinds of social factors increase the risk of schizophrenia.
Hey, Adam, Emmanuel just asked us a question. Is it accurate to say that it takes at least 2 major life stressors to activate schizophrenic symptoms? That's a good question.
That is a good question. I've never come across that as a rule. It's true that that people who wind up developing schizophrenia have often been through very, very stressful experiences. But I don't know of data about it being 2 or greater.
Thank you.
It's an excellent question. I want to go back to the video that we saw, because in many ways, if my teaching goals for this session are, if I get some people to read Professor Sacks's book, I'll feel that I was very successful. Or to go back and watch the rest of her talk, or she's got longer talks that you can watch. I think that some of the things that I wanted you to take away from that were, first, that psychosis is a very scary, painful, distressing, awful experience most of the time. Not all the time. There are sometimes that people, particularly who are manic and get psychotic, initially become psychotic in ways that they find exciting or exhilarating. But if they keep getting sick, that tends to go away and it all becomes very, very frightening. And you heard Professor Sacks say, imagine having a nightmare while you were awake. And I've talked with lots of patients who are psychotic, and hearing them describe their experience really, if you want to try to empathically connect with that, thinking about your own worst nightmares and is a pretty good way to go about doing it. The other thing that I like about her talk was that she mentioned at one point where she was talking about how terrible the experience of being restrained was. She said that she doesn't agree with the idea of restraints. I don't agree with her about that. I think that she may not have actually needed to have been restrained. That may well be true. But I do know that I've seen patients where if they weren't restrained, they were going to do something terribly, terribly violent to themselves or to other people around them. Now, the thing, though, that she gets at, which I really like and is worth listening to, is that if you do it, and sometimes you need to do it, you shouldn't take it lightly and you should never become calloused about it, because it is a trauma often to the patient who's being restrained. And these are often people who have already been through trauma. Right. So when you do it in psychiatry, you do it only because you really are sure you have to. and you do it with as much attention to the person's dignity as you can. So,
Adam, this is an era where I think we're really revisiting socially, law enforcement, EMS wise, how we restrain patients. With the George Floyd tragedy that occurred, we actually created a new program called Advanced Mental Health Life Support, a 4-hour training program, including the physiology of restraints. If you put someone face down with a knee in their back and prevent their ribs from moving, you remove 50% of their air movement, and you can kill them. Their oxygen drops and their carbon dioxide goes up. So what you said is so right.
thank you. Thank you. We have to be very, very careful. And then we have to, when people are in restraints, we have to be checking and watching them very, very carefully to make sure that they are continuing to be safe, and in terms of all the medical things that you're talking about. That experience that Professor Sachs had of hearing somebody say, they're not like us, that person talking to her, not knowing that she suffered from a mental illness, that gets at the way in which these are illnesses that are stigmatized, right? One of the things that I try to really impress on our students and our residents is that if you come into psychiatry, you're going to work with patients who are up against stigma in the world. And what that means is that they've got the problem of their illness, and then they've got the problem of how people and society react to their illness. It adds an enormous insult to the injury. Why are mental illnesses stigmatized? There's lots of different reasons. Some is that there are still many myths about mental illness. There are many people who still think of it as character weakness. There are communities that think that it's completely a spiritual problem and not a brain problem. There are people who feel that there aren't real mental illnesses, but that these are just ways of trying to control creative people, or that this is really all being driven by drug companies that want to make more money. Not to say that drug companies wanting to make money haven't done some pretty harmful things in the world of psychiatry, because they have, but these are real illnesses, and there are medications, and thank goodness that there are, because they can be life-saving. One of the other myths about psychiatric treatment is that patients don't get better and our treatments don't work. One of the things that is most appealing to many people about going into psychiatry, and then turns out to be our experience, is that we are often uncertain about what is going on with the patient. We're not sure we know exactly what the diagnosis is. As you heard me say, we're not sure we understand what the underlying psychology and biology and all of the causal pathways are. And yet, it's very, very unusual that I can't really help a patient. We can be enormously effective in psychiatry. And then finally, people with mental illness make people frightened. They get frightened of the possibility of violence. People get frightened at the idea that maybe if I spend time with people who are mentally ill, I'll get mentally ill. But mostly, we as a species, we have brains that tend to very easily and automatically categorize things into us and them. And it's very, very easy for people with mental illness to be considered the them. Now, is this DJ, is this a place where we're supposed to stop for questions?
Yes, so this will be our first Q&A session, and then we'll go on with your journey, if that's okay.
Absolutely.
Okay, first off, What is something that you wish the general public knew about psychiatry and mental health in general? More of a broad question to start it off.
I wish people knew that we actually know how a lot about how to treat people with psychosis so that they have much better chances at recovery and functioning lives and working and having relationships and not being in the hospital. We know how to do that, and we are not, as a society, been willing to pay for it. So in Texas, for example, we have some wonderful first episode psychosis programs. These programs work. They change the course of people's illness with psychosis. But they involve things that that take funding. And we probably need about 10 times as many of those first episode psychosis programs. We, as a society, we haven't been willing to commit the resources to treating these illnesses that we do to treating illnesses like cancer or heart disease. We still are too accepting of the idea that somebody with psychosis might get picked up by the police instead of by a team of mental health professionals, a crisis team. Instead of that, we are too accepting that people will just get picked up by the police and taken to jail. And it's a travesty. At any point, there are more people in jails in this country being treated with psychiatric medications than there are in psychiatric hospitals. That's a travesty. And it's because we have what we call jail diversion teams that of mental health professionals, crisis intervention teams that go out when 911 is called instead of the police arriving. This kind of team does, and it diverts people away from jails and back into the mental health care system. Those things work, but we need so much more of them than we have. So that's the main thing I want people to know. And this is why advocacy is essential in being a psychiatrist. You can't be a psychiatrist without getting to a point where you want to get your voice heard and advocate for our patients.
Thank you for sharing that. I'm sure many of the students in the audience did not know the scope of that issue. Next up, how do you think that the DSM could be improved, if in any way? There's been a lot of controversy in the psych community surrounding the DSM and the topic of diagnosis in general. And particularly, it says historically that the DSM was used to misdiagnose marginalized groups that deviated from societal norms. So could you touch on that?
Yes, the DSM is the best we can currently do, but it's not good enough. It's like they'll line about democracy being, the worst possible form of government except for all the others. So the DSM is like it's the worst way to diagnose mental illnesses except for any other option, right? It's good. It's been good at reliability. And that's something. Reliability means that if I see a patient and I come to the conclusion that this is psychosis and schizophrenia, then another psychiatrist or Dr. Fowler is also very likely to come to the same conclusion. And what that means is that then we can do studies because we agree on who we're putting in the studies to show that some medication actually will work for those people who we can describe in the same way and come to the same diagnosis about. That's reliability. And it's valuable. It is. It's something. It's not nothing. It's made an enormous difference in how much we can help people. Validity means, however, is different than reliability, right? Reliability means that if we that we all come to the same conclusion, it doesn't mean that we're all right. Validity would mean that we're actually able to know exactly what the illness is and get it right each time. So can the DSM be improved? Yes. And the way that it's going to ultimately get improved is through the integration of the things that it does well, which is symptoms and observable behaviors and those kinds of checklists, and integrating that with the kinds of biomarkers that Dr. Tamig and her group have been working on, and Dr. Trivedi, one of our folks who does research in depression. So we will in the next number of years get to that point. If people, there's a wonderful literature now that the NIMH, which funds research into mental illness, the National Institute of Mental Health, about 10 years ago said to everybody applying for grants, you know what, we want you to start asking us for proposals that don't focus just on the DSM diagnoses, but that focus on what they called the research domain criteria, that focus on things that are more rooted in the neurobiology, like experiences of cognition or experiences of affect. So we will get there. Now, then the questioner asked, well, hasn't the DSM been used at times to oppress people who are marginalized? Yes, it's a document that's created by committees of experts, and committees are people, and they make mistakes, and things evolve over time. So there was a time when homosexuality was a pathologic diagnosis. It's an embarrassment for psychiatry. There were, it's not that, so that's one example of diagnosis being used against people who are marginalized. Schizophrenia has been overly diagnosed in Black people, particularly Black men, for decades, and this really got heightened in the 60s and 70s when the criteria for schizophrenia began to place more of an emphasis on aggression, and people who were seen as aggressive and angry, which at the time, because of social change and social movements, included a lot of Black men appearing in emergency rooms, led to a lot of overdiagnosis, and that continues to this day. We still have disparities and distortions of how we make diagnoses based on race in this country. So we've got a lot of ways to improve, lots of room to improve.
Adam, I entered medicine 48 years ago, and the DSM-1 was just coming out, and it was this thin little Xeroxed copied thing. It's now a massive textbook and has been vastly expanded. Was it DSM-5 now?
Yeah.
And has the human brain become so much more complex in a half century, or is it we've just come to realize that there were so many more diagnoses?
It's a great question. You know, I have a slide that I show our residents with, which is a stack of all of the DSMs, and a picture of the 1, 2, 3, 4, and 5, and you can see each one is a thicker volume than the one before. This is a problem, and this is this is a good example of the way in which science and medicine are inseparable from social forces. And one of the social forces are that first, experts become enthusiastic about the things that they're expert in, and people like to find and name new syndromes in medicine. That's a problem. It's also a problem that we can see a proliferation of diagnoses at times that are driven by marketing for a medication. And then, so we have both the problems at times of proliferation of diagnoses, but also of overdiagnosis of things that have already been in the DSM. As I said, it's an imperfect system.
Maybe one or two more, Aditya, and then we'll go on to the talk.
Yes, sir. So we'll do two more. First off, how do you develop relationships with your patients, especially those who may be hostile or distrustful of you or medication? How do you help patients stay compliant with their medication and other treatment plans?
The way the question is really asked, how do you get people to trust you? And there's nothing magical about it. You can really think about, how do you get the people in your life to trust you, right? How do you get people you have relationships to trust you? You do it by being present, by being trustworthy, by listening, by caring, by being honest, right? They're really not things that are unique or different about what you have to do as a psychiatrist or as any kind of doctor, right? You build an alliance with anybody who's sick. It doesn't matter whether it's psychiatry or anything, by coming in and saying to the patient, first of all, I'm interested in hearing what's really wrong from your perspective. That's the first thing. The first thing that you always do is you want to know, tell me what you're experiencing, what the problem is from your perspective. And you take it seriously and you care about it, and you try to help the patient feel that you're trying to understand it. You don't have to understand everything. People respond often. Most of us respond very well to a doctor who's just trying to understand. Because if somebody's trying to understand, then they're conveying to me that a lot of things. They're conveying to me that they care. They're conveying to me that they're not freaked out by whatever I'm presenting with. They're conveying to me that I'm not alone with it. So those are the things that we can do. Now then, what else can we do? We can say, here's how I understand what's going on. And because this is the way I understand it, I feel hopeful that we can do things. Now, sometimes just that hopefulness is enough to help a person take on, engage with you, and begin to see the illness in a different way, and to see your treatment plan as something that they'd like to adhere to, and they'd like to take those medications. Sometimes it's more complicated, and sometimes there are patients who basically say to me, well, Dr. Brenner, you seem like a very good guy, and I appreciate all that you've done, but I don't see it this way. I don't think that I'm really sick right now, and I don't think I need that medication right now. And then, okay, again, the vast majority of the time, I'm just going to have to respect that. You can't make anyone comply with medication. You can get a court order, but that's not a long-term solution. In the end, what you can do is explain your perspective, listen to their perspective, and invite them to accept the help.
Adam, sometimes patients have a euphoria associated with their mental condition, which when you not only talk to them, but medicate them, it actually ends up being, it diminishes that euphoria. And so they don't feel quite as upbeat as they did. And so how do you tell them, said, no, you don't need to feel that good and that euphoric?
The patient who I mentioned before with bipolar disorder, who's started treatment with me 4 times, we were talking about that recently, and it's true. A little bit of mania, what we call hypomania, feels very good to a person. And it can actually even make them at times be more productive or creative. The problem is that that's not a stable state, and it tends to get worse. And so, I've often had the conversation with people over the years of, yes, I get that it feels very good when you're like this, and it won't feel as great if you take this medication that'll, dull things down a bit, but it will allow for all kinds of other good things to happen in your life. All you can do.
Yeah, I think of sort of the mix of physical with euphoria. I saw a patient a while back, middle-aged, came in advanced liver failure, cirrhosis due to alcoholism. And the alcoholism was quite closet. I mean, the patient knew it was going on, as did the significant other, but finally came in cirrhosis and ascites. And I said to the patient, you can never drink again. You are killing yourself. And the patient admitted to 4 or 5 drinks a day, in which, the old phrase ×3, which is bottles and bottles of alcohol per day. And then I said that to the patient, and the patient said, okay, but can I at least drink the communion wine? And the wine served at communion. And I said, this is going to be a hard row to hoe here. This patient really, really doesn't want to stop drinking.
Yeah. Well, addictions are their own kind of brain disease, and brains change in the state of addiction. And one way to think about it is that addictions hijack normal parts of brain function. Alcohol does things to the brain. Drugs do things to the brain that are part of normal function. They increase sociability or increase feelings of excitement. They activate the reward, what we call the salience and the reward centers, the parts of the brain that say, this is something cool, this is something that matters, and this feels good, this is rewarding, this is and addictions hijack those, take them over, and make it almost impossible for a person in the addicted state to think about anything other than now that object, that thing, which will give them that sense of, this is the thing that matters and hits all of my reward reactions. It's very, very hard. It takes a lot of help to quit. It often takes medication-assisted treatment, and it takes often a community.
Right. Well, Adam, you've got a story to tell us. You want to move to the next phase and
Sure.
Tell us a bit about you.
So I'll be very brief about this because how did I get to psychiatry? It is there are so many different ways. So we'll get to that in a moment. But here's how I got to psychiatry. I went into college and I was both pre-med and a philosophy major. And I should also say that when I came into medical school, I hadn't any thought about psychiatry whatsoever. I came into medical school thinking I would do oncology. And that had to do with family experiences of growing up and having cancer in the family and seeing what the doctors did. But once I got to medical school, a couple of things happened. I mentioned before the first experience and how compelling it was meeting people with serious mental illness. Another thing that happened was that I did think that the course about the brain was just, to me, fascinating. I could learn the things that we were reading about the kidney, and I kind of was happy to learn it, but it still felt like work. Learning about the brain didn't feel like work. Learning about the brain felt like, I just want to learn this stuff. So there was the intellectual fascination. But still, even with all of that, I wasn't thinking about psychiatry at all. And I didn't start to really think about psychiatry until midway through my second year. I had been really dealing with depression and anxiety since college. And I hadn't wanted to admit it. There was stigma that I felt about these things. I didn't want to even think that was true about me. But finally, as a second year medical student, it got too bad and I couldn't avoid it anymore. And I went to student mental health, and a couple of wonderful things happened. I saw a psychiatrist who, as I said, wasn't freaked out, and in fact said, we can understand this together, and then I can help you. And he did, and it was enormously helpful. And treatment was effective and useful. And I found then that I found myself thinking, wow, this person is so helpful to me. I wish I could do that kind of work and be helpful to somebody else like that. I also then realized that there were a lot of things that I had done in the past that kind of looked like I was heading towards a career in psychiatry. As a philosophy major, I was interested in things of theories of relationship and meaning and existentialism, lots of things that have a lot of overlap with things in psychiatry. I spent a lot of time in college working as a volunteer on a crisis phone line. In other words, there were a lot of things that if I had been willing to let myself think about it, I would have been thinking about psychiatry, but I wouldn't let myself think about it because I wasn't ready to get help myself. Once I was able to get over that hump, the whole thing opened up. And then it was, I tried to go into the clerkships in the third year of medical school with an open mind, but it was really done. I had fallen in love with psychiatry. So
Adam, I found that in my third year that every rotation that I took, that they were nice to me. That's what I wanted to do.
It's really interesting. I had struggled in the first year of medical school because I wasn't loving it, and but once I found that I had found this thing that I knew that this is the work for me and this I love, then it also opened up. I began to love all of it, because it was then just like, wow, this is all going to be useful, because there's nothing in medicine that isn't going to have some impact in psychiatry and vice versa. So that's how I got to psychiatry. Now, my point is that that is just one way that somebody gets to psychiatry. One of the things that I love about psychiatry is this. We need a lot of different kind of people in psychiatry. Because psychiatric illnesses are so complex, we need to approach them from so many different directions. And we have people who come who get excited about psychiatry because they start with biochemistry or they start as neurobiologists. We have other people who get excited about psychiatry because they really start in terms of concerns about social issues and issues of marginalization of groups, for example, and find their way to psychiatry that way. We have people who are undergraduate majors in literature and poetry, and that's a fabulous and incredibly important way of learning about the mind and learning about people's narratives, and they find psychiatry. One of my current chief residents was an engineer, did mechanical and electrical engineering at University of Texas, and then worked in that field for several years before coming to medical school. She is doing incredible things now with devising some really, really cool engineering solutions to psychiatric problems. There are people who come to us from backgrounds in music. There's just so many different kinds of ways to be a psychiatrist, and there's so many different places you can start from. I'll be quick about this. This is Parkland. This is our largest teaching hospital, and we're very proud of this. I'm very proud of this hospital in part because this is the place where all of our public sector psychiatric treatment goes on. This is the place where everybody who doesn't have insurance or is underinsured or is undocumented, anyone who doesn't have resources comes here and gets treatment. And one of the things that I think is very, very wonderful about this is, and that I like people to see this, is that this is a beautiful place. We don't need to do public care in second-rate sort of ways. This is a hospital that any of us would feel good about and feel a sense of dignity in walking into. And so we do psychiatry everywhere in this hospital. So up here on the 17th floor is our inpatient unit. So there are people doing inpatient psychiatrists, hospitalists are up here. We have consult psychiatrists who see the patients who are medically and surgically hospitalized and having psychiatric problems all over the hospital. We have people who specialize in emergency psychiatry and do that full time down here on the first floor in the emergency room. We have people who do interventional psychiatry, who do ECT or deep brain stimulation or ketamine treatments, all kinds of new interventions. And then we have outpatient psychiatrists. We have got outpatient psychiatrists who, in community mental health, that's in the Parkland system and in other systems. People also do outpatient psychiatry in private practice and academic health systems. To give you a little sense of the kind of range of things, some of the questions that I often get asked by new medical students are there subspecialties in psychiatry? This is the list of current board-accredited subspecialties: addictions, geriatric, consultation, forensic, and child and adolescent. We have enormous need because of the public mental health burden. We are in an addiction epidemic in this country, and we have seen a huge opioid epidemic and overdose epidemic and death by overdose over the last decade. We have great need in addiction. We have an aging population, and we have enormous needs in geriatric. we have far, far fewer child and adolescent psychiatrists than we need in this country and everywhere in this country, but certainly in Texas. I also get asked about combined training. There are combined training programs where people do both medicine and psychiatry, neurology and psychiatry, and even what we call a triple board program where people do pediatrics, adult psychiatry, and child psychiatry. I got asked to say something about what a day in my work looks like. I decided to show you a week instead because it better sums up the fact that I love being in academic psychiatry because I get to do a lot of different things. The initials are initials for patients. I get to see individual patients. I get to do recruitment for our combined program. I get to supervise residents in the outpatient clinic at Parkland. I get to host the Psychiatry Morbidity and Mortality Conference. I get to work on building new kinds of programs like a social work fellowship program. I even got roped into being part of a podcast.
Adam, you left off the admissions committee on Thursday night. Adam, could you comment a word or two about your work on the admissions committee? You and I have worked together for many years on that.
Yeah, I'd love to. The admissions committee is an incredible privilege. It's a lot of work because the committee takes its work so seriously. I mean, we do a truly holistic review of every applicant. You know, every applicant gets several interviews and then gets assigned to a member of the committee like Dr. Fowler or myself. And we sit down and read through every document and every letter and every essay and look at everything that people have done. And it takes a lot of time, but one of the things that's really wonderful about it is that people write the most beautiful things about what experiences have brought them to medicine and what their dreams are and what they want to do. Their aspirations are, I find it every year, it gets me back in touch with the things that it reminds me what's important about doctoring. It reminds me again and again about what matters. So it's a great privilege to be part of it. Over time, we learn a lot, Dr. Fowler, about do's and don'ts of applications. So I've become a good advisor to people applying to medical school over time.
Well, Adam, during the year and a half we've been doing virtual shadowing, I've said to the folks online many times, I said, please, you're going to work so hard to get in school, whether it's med school, PA, or NP. Please don't drink and drive. Please don't get caught with marijuana on campus if it's not legal, because you're going to end up having to explain that on the application. And it just might end up pulling the rug out from under you or making you a less competitive candidate. You know, after all, you're interviewing for what will be a $6 million job. Let's say it's $200,000 for 30 years or $300,000 for 20 years. And, you know, and if you've got a lot of great candidates lined up and you are the only one that is having to explain that you broke the law or that you've been placed on some sort of monitoring, then you know, just don't do that. I sound like grandpa when I say that, but the thing is that from a professional standpoint, it's true. So
that's right.
Yeah. So Adam, pretty competitive this year, right? We've had a lot of great candidates and, you know, we've had 6,000 applicants. We invited 800 and boy, they just keep coming. So a lot of competition, huh?
That's right. But one of the things that I have really liked seeing in our committee, I think I've been on the committee for about 10 years now. And I think that there's been a growth towards more flexibility about what a good medical school applicant looks like. In other words, we used to bring up somebody get labeled a non-traditional applicant as if this, were a big deal or a concern that they did something for several years before they went to medical school. Now we don't even give that a thought, and in fact, we generally appreciate, as we should, that people went and got some actual real world experience before coming to medical school.
I've been with you for 10 years on the committee, and I would say 10 years ago, we didn't see many gap years being taken. Now, I would say, what do you think, a third maybe of the candidates, Adam? And so the gap year is very important. Just to finish my thought, only to say,
Yes.
but use your gap year to do something. We've had a candidate recently that said, I'm just really taking a year off. I'm going to rest and I'm going to. Well, I understand that, but you're a $6 million professional moving into a professional career that's going to be very difficult. And I'll just finish the point by saying I like to see folks that take a gap year to do something, go do research, get some traveling in, maybe stay in taking some courses, post-baccalaureate work, but make it a worthwhile year that contributes to your future. That's all.
That's exactly right. Really, there are so many things that you can do that will deepen your understanding, your appreciation of medicine and healthcare, of the things that people are, or of social issues, the things that people are up against in the world. And if those things don't seem like they would be rewarding things to do with much of your time during a year or two or three off, you're unlikely to really love your life in medicine.
I'm also, Adam, very impressed about how important the interviews are. We'll have a 4.0 candidate with great MCAT score and does a lot of community service and shadowing. But if the candidate comes and just really doesn't interview well, and examples of not interviewing well, let's say you did some research and then the interviewer asks you about the research and you really can't explain what you did, or about a paper that you wrote, a truly professional candidate would be able to do that.
That's great. That's absolutely right. Anything that you put in your application, you should expect to be asked about, and you should be prepared to be able to talk about it.
Adam, we did 8 years of interviews in person, and then you and I, the last 2 years, we did 2 years of virtual interviews. Would you say that there's been much change really in the interview process? Can you tell much difference in terms of in-person versus virtual? Let me go first. Not really, not to me. What's impressive sometimes is that the interviewer will say, we couldn't make the screen work, and my candidate was able to help us get the screen working. That doesn't happen in person.
Yeah, there's on the one hand, there's the glitchiness of the screen. On the other hand, there's saving people all of the expense of traveling to interviews. I think that the pluses of the savings and the savings, one of the things that is really true is that the expense of traveling around the country to interview does not fall equally on people. There are people who come from families and worlds where they've got a lot of resources for those things, and other people where it's much, much harder to do. So I think that in-person interviews are a little more fun. It's a little easier maybe to connect, but it's a shade of gray, and I have to say, I think that the increase of just the equity of it outweighs it. I kind of like the idea of staying with it virtually.
There was an article in healthgrades.com today, which I'm going to put in chat for everybody, which has to do with the interviewing process and the folks that are coming to school. I read this week that as many as 1 in 5 medical providers, active medical providers today, are dropping out. At the same time that we've never had more applicants ever for medical school. Last 2 years ago, 44% of applicants for med school found a spot. This past year, it was 41%, Adam. So it's very, very competitive. That's an awful lot of work. And so one last thing, be prepared to answer the question for the interviewer. What are you going to do if you don't get in school? If you really want to help people, well, then how are you going to help people if it's not as a physician or NP or PA? How else are you going to help people?
Yeah, I thought often that I would. One of my backup ideas was that I would want to be a teacher. And so one of the nice things is I wound up getting to be both a doctor and a teacher. But I also remember at times then feeling like, I remember as an intern in my lowest month in the middle of internship year, when I was really having a hard time of it, doing the ICU in medicine. I remember thinking, I don't know, I don't know if I can do this, but I'll never be able, if I leave now, I'll never be able to pay off these loans with being a teacher. So I'm looking at the chat, which I haven't seen up till now. Somebody wrote, I think somebody wrote something about the schedule. Maybe that was when I put up my schedule, which might have looked a little full.
Well, these are busy days, these are dawn to dusk, and with us having virtual meetings back to back, as I know you do 8, 10, 12-hour virtual days, on the Thursdays of admissions committee, for me, we started our EM conference at 7:30 in the morning, and then we finish, our admissions committee meetings are 68 candidates in 4 hours. And so, those are 14-hour Zoom days. So academic life is pretty busy, Adam.
Yeah, it's busy, but it's really interesting. I like my work life because you were saying about doctors dropping out of the profession. Burnout is a big problem in medicine, and it's valuable to think about actually what causes and what prevents burnout. And certainly you can burn people out just with the sheer volume of work. Like I can work those days. You saw a bunch of long, busy days. But if I tried to do that and be working nights and weekends on an inpatient unit on a rotating schedule, that would push me over the edge. I don't have a call schedule, right? So you can burn people out just with the volume of work past a certain point, but the volume of work is not the most critical thing. The main things that burn people out are, do you find the work meaningful? Do you feel like you're part of a team of people that you share the work with and that you're all, supporting each other in it? And do you have some control over your work life? And if you've got those things in place, you can prevent a lot of burnout.
Yeah, it works for me because in emergency medicine, we do our schedule 4 months in advance in the ER. I'm a division chief, so I have, half of my job is administrative duties, which includes, like you, hiring new faculty, interviewing for the residents, attending oodles of various staff meetings from QA to you name it, all of which are important. And then, of course, we have virtual shadowing on Tuesday evenings. And Adam, I don't know, I know you can't tell. You've been talking for 2 solid hours. God bless you.
Ray, I could talk to you for 4. I've always left our admissions committees wanting to hang out with you more.
Absolutely. Adam, if you could put your slides back up, we're going to go to show the students how they can take the exam.
Oh, yes. Sorry.
Yeah, pop that back up so we can show them how to take the exam. And we're going to let you get to bed here. I know you've got a long day tomorrow, and I've got to be in the ER at 6 in the morning tomorrow. So I'll be in urgent care tomorrow for the first time. So thanks, Adam.
Okay.
All the way to the end. Just drag it all the way down. There it is. That slide right there. that just leave it right there. Aditya, you want to chime in?
Yes, sir. So this week's sessions quiz will be due next week at 6:59 p.m. Central Standard Time. You must earn a grade of 70% or higher in order to earn a certificate. Please keep track of the certificate, download it for your records because it shows as proof of attendance and verified hours. I will be sending a link in the chat to the quiz as well.
Thank you, Aditya. And so for all 165 of you that came tonight, we want to thank you so much. We're going to keep being here if you keep coming back. And this is our 79th lecture. We've had 500,000 viewings of our talks. So clearly there are folks that like this kind of contact. Now I want to ask all of you to put "Thank you, Dr. Brenner" into chat so that he can see the chat. And why don't you drown him in thank yous very quickly? There you go, Adam. There. These are the folks that love you from all the way from Thailand to Australia by way of Texas today. So anyway, folks, we want to thank you so much. Dr. Brenner, what a wonderful talk tonight. You're so full of humanity and kindness and understanding. And this was so erudite and illuminating for all of us. And so we're deeply, deeply grateful. And on behalf of the whole working group, we just appreciate your time and your grace and your willingness to come and be a part of this. So thank you to all. Oh, Adam, I would say this, we're going to post your talk online, and we typically have about 5,000 people that end up watching the talks from all over the world. Each of those 5,000 will go on to be a medical provider in their career and probably see about 100,000 patients. 5,000 times 100,000 is 500 million. Tonight, Adam, you've touched 500 million lives through your extended reach. And so we are deeply, deeply grateful for your coming to join us. So to all of you, on behalf of the whole virtual shadowing team and Dr. Brenner, we want to thank you for coming. We'll be here next week with Dr. Dan Septum, whom Dr. Brenner knows well, family physician, also on the admissions committee. Dan is a wonderful man, wonderful physician, and I know you'll enjoy him. So